So let's talk about DKA today, Diabetic Keto Acidosis. The management and diagnosis is truly in the name, and what's really important to know is that if you're on night float, this can kind of ruin your night because of how frequently you need to be on top of things. So, diabetic ketoacidosis. You get this if you're type 1 diabetes, right? Your pancreas cannot make insulin, so the glucose cannot get inside your system. So if you end up missing your insulin at home, your glucose is going to go sky high. You can see it in the 500, 600s, even 1,000. The next step is keto, right? Your body is starved for glucose, starved for energy, because you're not able to make the insulin to make the glucose go inside of your cells. They are starved, so they're trying to make energy in any way they can. And the way they make it is in the form of ketones. And ketones are inherently acidic. Diabetic keto acidosis, meaning the acidic ketones go inside your blood and cause it to be acidotic. And this is how you get your symptoms, right? You have acid in your blood. Your body's going to try to compensate by trying to blow it off with your lungs, right? CO2 is acidic, so you're going to get small breathing, rapid respiratory rate, abdominal pain, nausea, vomiting, diarrhea, and especially dehydration, right? If you think about it, you're going to be hyperglycemic, and so you're going to be peeing out all this glucose, and so your body's going to be drained of fluids. So the way to treat this is by thinking backwards in the way DKA, right? Think about your symptoms. To get rid of those symptoms of small breathing and abdominal pain, you gotta rid yourself of this acid in your blood. So to get rid of this acid in your blood, you got to get rid of the ketones. To get rid of the ketones in your blood, you gotta make sure that your cells are not starving. And to make sure that your cells are not starving, you have to make sure that the glucose in your blood, that's sky high, gets into your system. And of course, this is the inherent treatment of DKA. You're dehydrated, so we give you fluids. You have to get your blood glucose inside your body, so we give you insulin. And when we're giving you insulin, we know that aside from putting glucose in your body, it also shoves potassium inside of your cells as well. So you want to give potassium as well. So 3 things that you want to give. So let's talk about the first things first. You're extremely dehydrated. You want to make sure you're giving them adequate amount of fluid. So the first thing our thought goes to normal saline, right? It's a resuscitative fluid. You can give this. So if someone comes in and they're hemodynamically unstable, MAPS less than 60, blood pressure is tanking, tachycardia, terrible, cannot, keep hemodynamically stable, send them to the ICU. They need pressors. It's not inpatient level of care. But if they are maintaining their blood pressure okay, you want to, and you see that they're severely dehydrated, like terribly dry oral mucous membranes, or skin turgor is like terrible, like an old man, then give them normal saline at 1 liter per hour. But what's most likely going to happen is going to be a mixed picture. They're going to have mild hypovolemia. And again, this is a clinical decision. But 99% of the time, they're going to be mildly hypovolemic. So you want to adjust your fluid based on the serum sodium level in the BMP, right? The sodium level, it's not accurate in DKA because let's say, for instance, that your sodium level shows as 145. Looks normal, but you have to correct for the hyperglycemic state inside of your body. So the trick to doing this is if you take a normal blood glucose of 100, every additional 100 units of blood glucose, you're going to add 1 point to your serum sodium. For instance, if your serum sodium shows 145 and your blood glucose shows 500 blood glucose is 400 above its baseline 100, meaning you're going to add 4 points to your serum sodium. So if your original serum sodium was 145, you're going to add 4 units, so 145 to 149. So now you have high serum sodium, right? And so in this case, you don't really want to give normal saline. That's going to be giving more sodium. You don't want to go high, right? Remember, low to high, your pons will die. You'll get locked-in syndrome, and high to low, your brain will blow, cerebral edema. So you want to make sure you're correcting sodium as well, not too fast, not too slow. So you have a high sodium level. So you want to give less sodium. So the ideal choice of fluid is half normal saline. The rate you want to keep it at is between 250 and 500 cc's per hour, depending on, if they have other comorbid problems like congestive heart failure that can back up fluid. So you can, let's say you get 500 in this case. So now you have your IV fluids correct, running at 500 cc's per hour, half normal saline. Great. Now let's move on to the insulin, right? The whole point is to get blood glucose inside of your cells to prevent this ketones, to prevent the acidosis. Now, when they come to the ED, immediately based off the DKA profile, you should be getting insulin through an IV route. You give a bolus, right? A 0.1 unit per kilogram bolus, which equals to usually 10 units of insulin immediately right away. And then right after this loading bolus, you start them on an insulin drip. And here is where you start to monitor things very carefully. You start them on an insulin drip at 0.1 units per kilogram per hour. And this is a continuous infusion. All right, so now you have your fluids and now you have your insulin running. But remember, as insulin is going to shove glucose inside your cell, it's also going to shove potassium inside your cell. And what happens if you have too low of potassium in your blood and you overcorrect? It can cause cardiac abnormalities that can get a heart attack and die. So you don't want to cause any iatrogenic problems. So you want to look at the potassium level. You know, if their potassium level is low, you want to give them more potassium. If their potassium level is normal, you still want to give them potassium, because this potassium is going to go lower if you don't give potassium now that you're giving insulin. Okay, so let's say their serum potassium level is normal, 3.3 to 5.3. This means that you give, in the fluids that you originally started, 20 to 30 milliequivalents of potassium in each bag, just to make sure that the insulin is not going to screw over your potassium and cause a heart attack. Okay, and then the other part is bicarbonate, but if your pH is less than 6.9, you can give bicarbonate, but this is an ICU level problem, so you should not be dealing with this. Anyways, let's get back to what's happening right now. You have fluids running, half normal saline at 500 cc's per hour with potassium chloride. Now you also have insulin running at a 0.1 unit per kilogram rate. It's a drip. You have your fluid drip and your insulin drip with potassium. Now, with insulin running, your blood sugar is going to go down, right? It's going to go down from 1,800, blah, 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 lower. So you want to make sure you're not going hypoglycemic. So you want to be checking a few things every hour, every 2 hours. You want to be checking a BMP to make sure that your anion gap is correcting, because your end goal is to prevent this acidosis. And the way you check this is by seeing that the anion gap has normalized. You also want to be checking finger sticks very frequently, every hour, because you want to make sure that you're not dropping your blood sugar too low. Now, eventually, the blood sugar is going to go down to a normal level. Once it hits the threshold of 200, right? Once it goes below 200 blood sugar, you want to make sure that you adjust two things, your fluids and your insulin drip. Right now, your anion gap is likely not normalized. So you want to keep the insulin drip going, but you want to half the insulin drip. If it was at 0.1 units per kilogram per hour, half it to 0.05. This is to make sure that you're still correcting the anion gap by allowing blood sugar to go into your cells, but you're not going to go hypoglycemic this fast. And because your blood sugar is now teeter-tottering 200, you want to switch your fluids to a slower rate. You can change to 150 to 250 cc's per hour, but you also want to change it to add D5 fluids, because you want to give sugar so your insulin drip doesn't cause any hypoglycemia until your anion gap resolves. So it's a protagonistic-antagonistic relationship right now. Now, finally, you're trying to maintain a blood sugar between 150 and 200 units until your anion gap resolves. Okay? Now that the anion gap is resolved, you're basically doing very well. Your DKA has done its job, right? Your diabetes blood sugar is now between 150 to 200. You're likely not making ketones anymore because you're not starved for blood glucose, and your acidosis has now resolved based on your anion gap. What to do now? Now you want to basically set them up for discharge eventually in the next few days. And how do you do that? Of course not in an insulin drip. So you want to get them set up with a basal bolus rate. Now that your blood sugar has decreased below 200 and your anion gap has resolved, the moment your anion gap resolves, you give them a diet, a carb consistent diet, low in sugar, but allows them to eat. Now they're eating because when they came in, you're not allowed to make them eat. They have to be NPO. So now that you give them a diet, you actually have to calculate the amount of insulin they've gotten over the past 24 hours based on the bolus they got and the insulin drip. So to make things easy, let's think about how to calculate this basal bolus dose, right? Let's say that over the past 24 hours, they've gotten 100 units of insulin. The average person who's insulin naive is going to need 80% of that total divided between long-acting and short-acting. So 100 units, 80% of that is 80 units. So 80 units divided by 2, so half of that is going to be 40 long-acting. And that long-acting is maybe like a Lantus 40 units I can give at night, later tonight. But the other 40 units, I want to divide into 3 TID meals, right? Lispro is a short-acting that I can give during mealtime. So 40 divided by 3, you can chalk it up to say 12 units with every meal, right? Breakfast, lunch, and dinner. And so what I want to do right now that the blood sugar has normalized, the anion gap has normalized, I want to, while the insulin drip is still running, give them 12 units of insulin when I give them a diet. Now I have given them an insulin 12 units Lispro, and I have given them a diet. 2 hours later, after I have done all this, I then stop the insulin drip, and this is my transition into them having lunch, 12 units of insulin, dinner, 12 units of insulin, and then at night, the 40 units of Lantus that I'm going to give them. And this is kind of their diabetic regimen moving forward in life. And then, of course, the fluids I can eventually taper off just based off hydration status. And so this is how you treat diabetic ketoacidosis. They come in high blood sugar, diabetes. They're making ketones because they're starved. And so this increases their acid level in their blood and causing all these terrible symptoms. And what I did was I reversed the symptoms by working my way backwards to DKA. Now, acidosis I treated by eliminating, by hydrating them, but also treating their high blood sugar by putting it into their cells. This made sure that their glucose was going into their cells. No more ketoacidosis because they're not starved, and I controlled their blood glucose. So they came in near death, but now they are fixed and they can have a proper insulin regimen. And then they should have close follow-up to make sure they're understanding how to eat and take their insulin as well. So overall, this was how to treat diabetic ketoacidosis.